supervisors and professors during my time in graduate school at St. John's and a formative influence on my passion for trauma-informed care. Dr. Brown is a professor of psychology and executive director of the Child Help Heal, Empower, Learn, Prevent partnership at St. John's University. Her primary clinical and research interests include the prevention and treatment of child trauma and post-traumatic stress disorder. She has participated in research on the assessment and treatment of sexual assault, child physical abuse, domestic violence, and bereavement related to traumatic circumstances such as 9/11. Dr. Brown has received funding from the National Institute of Mental Health, New York State Office of Mental Health, Substance Abuse and Mental Health Services Administration, Department of Justice, and private foundations to evaluate treatments for traumatized children and adolescents, many of whom are from culturally diverse and economically disadvantaged populations. She is the director of a Category 3 affiliate site of the National Child Traumatic Stress Network, housed at Child Help Partnership. She is co-developer of Alternatives for Families, a cognitive behavioral therapy, a treatment for family conflict and physical abuse, and a certified trainer of trauma-focused cognitive behavioral therapy, a treatment for traumatized youth and their non-offending caregivers. Dr. Brown is a member of several national and international organizations dedicated to improving mental health services for traumatized children and has served on the board of the American Professional Society on the Abuse of Children. She recently received the Mark Chafin Outstanding Research Career Achievement Award from the American Professional Society on the Abuse of Children. Please join me in welcoming Dr. Elissa Brown for her presentation entitled COVID-19, Promoting Children's Mental Health Through a Trauma-Informed Lens. I will also be monitoring the chat for questions and will facilitate the discussion after the presentation. Please feel free to also email or text me any questions or comments. And for those of you who don't know, my email is mara.demaio@hhchealth.org. And thank you, Dr. Brown, and we are looking forward to your presentation.
Oh, Mara, thank you thank you for inviting me. Thank you all for being here. I know how busy everybody is right now. It really means a lot. And I'm going to be talking today about disaster mental health, what it is, what do we know, what do we still need to know. I also, in addition to thanking Mara, I want to thank Rob and Vanessa for kind of making sure all the nuts and bolts were where they were supposed to be. That said, if there are any errors today, they are mine and mine alone. All right, let's see if I can share my screen. Mara, you let me know if there are any problems, okay? As we move to my PowerPoint. All right, Mara, we good?
Do not see a PowerPoint yet.
We do not. Okay. I'll try it again then. Huh, that's weird. It kind of does it and then it pops back out. You know, I'm going to close everything else I've got open just because one never knows what might be affecting things. Let's see. All right, so this is here. Let's try one more time.
Dr. Brown, how are you exactly going about sharing your screen? What steps are you doing? I just want to know what you're...
No, thanks, Rob. So I appreciate that. So I go to share my screen, and then I'm going to application window.
Okay.
And then I'm clicking on it's my PowerPoint, which says Grand Rounds at IOL, and then I'm hitting share.
Okay, we got it now. So now you can share. Now you can put your whole thing in the slideshow mode.
It always happens right when you know, maybe it was closing everything else that helped. I don't know, but I'm thrilled you guys can see. All right, I'll jump in. Thanks, Rob. So as Mara said, we're going to be talking about children's mental health through a trauma-informed lens. And I'm going to be talking a lot about kind of what we know in terms of intervention. For those of you who need this, I can leave it up on the screen for a minute. I also have it at the end of the presentation. So I'll just wait one sec there. All right. So why did I choose this topic when Mara reached out? My opinion is that every mental health professional is directly or indirectly treating the consequences of COVID-19 right now. And if you're not doing it right now, you're certainly going to be doing it over the next 6 months. I also believe that intervention is best when understood in the context of emerging research. And here we're talking about research in disaster mental health and specifically COVID-19. What I'm hoping that you guys will get from this is an understanding of the prevalence and predictors of mental illness following disaster. I want to help you think about how do we match what we know about the research and more specifically what you know about a given family with level of intervention. And of course, throughout this, we're going to be critiquing the disaster mental health research, particularly as it applies to children. I know you all know what this is, but I think it's important to just start with our basic definition. Some of this is DSM, some of this is sort of the trauma field more generally. We know that a traumatic event is an experience that is emotionally painful, distressing, and shocking, which can result in lasting physical and or mental effects. The latest DSM-5 talks about actual or threatened death, serious injury, and adds, I'm happy to say, sexual violence. And that traumatic event can be directly witnessed, directly experienced, or learned about through repeated conversation, particularly with a caregiver. Now, how does that compare with what we know about COVID-19? Well, first of all, COVID-19 is a chronic event, and of course, trauma can be chronic as well. COVID-19 has been unpredicted in every way. The experience itself was unpredicted. The duration of COVID-19, we're arguably still in the middle of it. The duration is unpredicted. The aftermath is unpredicted. It is a event or series of events that is impacting the entire world for the first time. COVID-19 affects everybody, but there is certainly devastation, differential devastation for certain subgroups. The threat of death is very much present for really, many, many of us. We've had to quarantine in a way we've never done before, certainly not in the last 100 years in this country. Natural sources of support are disrupted. And when I talk about the risk and protective factors following trauma in terms of the prediction of mental health problems, I'm going to talk about social support and how important it is. And right now, it's certainly not as we typically consider it to be. There are large economic consequences. I'm afraid to say the R word out loud, but certainly there are. There's overplay in all forms of media. Again, we're going to talk about that as a risk factor. And in the middle of all of this, or in addition to all of this, there's tremendous stigma and racism, starting with the Asian American community when COVID-19 was first discussed, and then moving into the events of this last spring and the Black Lives Matter movement and all of the pieces therein. And of course, not to mention, we're in the middle of what is a very, very heated election. Now, let's go back for a second. What does all of that mean? Well, it means that much of what we know about disaster mental health holds is very relevant. But when we look at the literature, the majority of the literature on disaster mental health is on things like hurricanes and earthquakes, which are mostly acute events. We do have some information on pandemics that I'll be sharing with you. But we are, to a certain degree, trying to make our best guesses on how to help, where to help, who to help, all of that. Now, the trauma-related mental health problems that have been very well established in the literature are the following, and you all being mental health experts know what these things are, and I think probably know that they are very common responses to interpersonal violence, motor vehicle collisions, other disasters, other forms of trauma. PTSD, GAD, depression, suicide, grief, somatic symptoms, all sorts of risky behaviors, meaning substance use, self-injurious behavior, non-suicidal, aggressive oppositional behavior. We see attachment and social deficits in children who have been through trauma, and academic and learning problems. And then, of course, all the work coming out on adverse childhood experiences, some of which are classifiable as trauma, are also showing serious physical consequences of trauma. All of that's very well established for adults and for children. I think where I want you guys to start to think a little differently is whether there are mental health problems that we need to consider as sort of COVID-related that we may not have considered trauma-related prior to COVID. So if you think about all this, and some of you probably have already, it just makes good sense. So we're seeing elevated OCD with all of the hand washing, with all of the, when back in the spring when we were washing our food, when we brought it back into the house. So we're seeing elevated OCD, we're seeing more agoraphobia, which of course is related to the fact that we are being quarantined and stay-at-home orders and all of that stuff. The separation anxiety disorder, there are many kids who are worried of something happening to their parents, and the clinic that Mara referred to that I run is in Queens, where there have been just horrific consequences of COVID and a lot of death. Particularly for the low-income multicultural community that I serve. So the separation anxiety is there. Social anxiety is creeping up because children can avoid very easily a lot of social interactions. And again, the hypochondriasis makes all good sense. Now, when we think about mental health consequences to trauma, part of what we do intervention-wise is psychoeducation, which really the goal of psychoed is just to normalize the mental health symptoms. And we're not saying we don't want to change it, we don't want to challenge it. Of course we do. We don't want kids walking around with these problems, but it is understandable that these would be consequences given what is going on. So we now have to have this broader way of thinking about a mental health response to COVID, because we have this historical literature plus some of these things that we didn't always think of as consequences. Now, what do we know about mental health reactions to trauma? There are lots of different ways they can appear. For some kids, they appear right away, and then they drop off. For some kids, they start to show symptoms, and then they actually get worse over time because other people kind of go back to normal and these kids don't. There's something called a sleeper effect, which we saw a lot after 9/11, where kids were fine for the first couple of months. Then December came around and it was time to get on an airplane, and a lot of the kids had this real surge in symptoms. Now, the reactions of children and adolescents vary very much. And they vary according to age, developmental level, and other risk and protective factors that I'm going to talk about in a minute. For the sake of time, I'm not going to go developmental level by developmental level, but just one helpful hint to parents, because I'm always thinking about, how do we share this information with caregivers, is they need to look for regression that's typical of a younger child. So a 16-year-old's acting like a 13-year-old, a 6-year-old is starting to tantrum like they did when they were 3. That is a very helpful hint for caregivers. Now, the role of caregivers is incredibly important all throughout the life of a child. It is not, the literature is pretty clear on this, when kids become teenagers, it's not that the caregiver role matters less, it's that the peer role matters more. So caregivers need to be a really central part of our thinking here if we're checking in on kids as pediatricians, as nurses, as mental health professionals, we must be checking in with the caregivers as well. However, we've got a couple of challenges here. One is that children, particularly young children, tend to be strongly affected by their caregiver's reaction to the traumatic event. And as you're going to see when I go over some of our 9/11 data, often the caregiver is doing worse than the child is. So if you're going to try to intervene, make a difference for that child, and the caregiver is really struggling in terms of their mental health, you're going to hit a barrier there. And so we really need to be thinking about the role of caregivers here. The second problem we have is that caregivers tend to underestimate both the intensity and the duration of their children's stress reactions. Now, this may be very adaptive, given my first point. If the caregiver is struggling, it could be just too much for them to realize how much their child is struggling. But we have to be smart about reporters, right? Who are we going to ask how this child is doing? The caregiver is an important person to ask. The child certainly is an important person to ask. Are there other resources who we need to reach out to, like a teacher or someone else who's been in the home and actually seen that child? Now, how long do reactions last following trauma? So disruptive feelings and behaviors found after an extreme trauma are typical. And what I mean by that is one of my favorite studies was done by Edna Foa, and many of you probably recognize that name. She is quite a leader in the area of PTSD and anxiety disorders and treatment in kids and adults. She did a really interesting study years ago where she assessed women who had been sexually assaulted within 24 hours of visiting an emergency room in Philadelphia. And she gave them a PTSD measure, again, 24 hours after the assault. And what she found, because she obviously had to exclude the 1 month criterion that we used to have, for PTSD, she had to exclude that because it was 24 hours earlier that the assault happened. She found that 94% of these women met criteria for PTSD. 94%. So to me, the reason I love that study is that I use psychoeducation so much with clients to help them understand their own reactions. And if you have PTSD and you are getting triggered by sights and sounds and smells and touches, then every part of your brain is reacting. And you feel like a pinball machine because the ball is sort of jumping from, the area of the brain that handles vision to the area of the brain that handles sound, and you're jumping around. And so they really need to have that sense of feeling like there isn't something wrong with that. For 94% of people, to me, there aren't many things that affect more than 94% of us. So we know that. We have that established, that soon after a trauma or bereavement, I should say, disruptive feelings and behaviors are expected almost. But we need to start distinguishing among this acute phase, which is sort of during the trauma, and some would argue where we are now, a transition phase, which is hours to weeks after the trauma, depending on the trauma, and more of the long-term phase. There have been very few prospective longitudinal studies of the trajectory of post-trauma mental health problems in children. So, this is it, folks. This slide is my attempt to kind of summarize what we know longitudinally with kids. And as you can see, all of these are, either human-made or natural disasters, right? I'm going to get to the pandemic research, but we don't have good longitudinal stuff on kids there at all. Annette LaGreca, who's done some of the best work, I would say, in this area, looked at kids after Hurricane Andrew. She studied them over time. And at 3 months post-hurricane, she found that 55% of children had moderate to severe distress, and 2/3 of those kids were fine 10 months, 9 months later. And 1/3 of those kids had chronic dysfunction. So kids that were struggling at 3 months and continued to struggle a year later. And so those are the kids we want to be able to identify, right, early on and monitor over time. Young et al. In 2018 published a paper on the Sichuan, and I'm sorry if I'm not pronouncing that right, earthquake. And they found that 1 month after the earthquake, you can see that the percentage of kids who had criteria for PTSD was about 17%, and 6 months later it was down to 11%. So it is sort of a natural recovery that we see. And by the way, NFL found the same thing in those women who she assessed in the ER, 94% within 24 hours, and 6 months later it's way down, somewhere around 20-25%. So. Joy Osofsky and her group in New Orleans looked at both Hurricane Katrina and an oil spill that had occurred, and she did this incredible work where thousands of children over 4 time points over 4 years. She found 4 patterns of responses in these kids. About half of the kids had low symptoms right away and continued to have the low symptoms over time. About 20% of them had initial jump in symptoms with a steep decline, and then again, low symptoms going forward. Some kids, 18%, had initially low symptoms with increases over time, and then this small group of 9% were high across the board. So we really see these different patterns, and we need to start thinking about how we identify those kids. We don't want to wait 4 years to know who's going to be most at risk. All right, let's look at the pandemic literature, and as I've said repeatedly, this is mostly with adults. There was a SARS study done on healthcare workers. I thought this was very appropriate given who I'm talking to. They found clinically significant distress in between 1/3 and 1/2 of the workers during the crisis itself. And those who were more vulnerable had to quarantine, had to treat their colleagues, had fears of contagion, concern for their family's health, job stress, interpersonal isolation, perceived stigma, and they had children, which is interesting because other studies having children is often a protective factor, but when you're worried about them, it's not. 2 years later, and by the way, it's the reason it's 1/3 to 1/2 is it was a number of hospitals that came together for the study. So 2 years later, the workers who were in the hospitals that directly treated the SARS patients had significantly elevated chronic stress compared to the workers in similar hospitals. And the stress was lower in workers who had more experience prior to the pandemic, better training, and more support from their hospital. So here we're talking again, as we always do, about trauma-informed care and making sure that it's at every level from the hospital on down. Now, SARS, the applicability of this study, we have to be careful because SARS did not have the community transmission that we're seeing here with COVID. Okay, so we've got a couple of COVID studies that are coming out, which I think is helpful. This is a study of COVID-19 in China. It's really interesting. They collected data on 1,210 adults from 194 cities over 3 days, from January 31st to February 2nd of this year. And they found that 17% reported moderate to severe depression, 29% are reporting moderate to severe anxiety. And the risk factors for these mental health problems include being female, being a student. So pay attention to this. This is going to come up again, this sort of young adult vulnerability. They have specific physical symptoms and they have poor self-reported health. So probably more anxiety and depression due to being concerned about their own physical health. Protective factors included having specific, up-to-date, and accurate health information. So this becomes really important, the communication piece of it. And I think we've seen that in this country as well. When the communication isn't good, people get very, very frightened. So having specific, up-to-date, and accurate health information is helpful, and having those precautionary measures was helpful. I'm sure many of you know about this study. There was a recent study done by the CDC where they compared the rates of depression and anxiety in 2020 to the same time in 2019. And this is so important because I live in a world personally of not mental health professionals, and I get asked a lot by my friends kind of, what's going on. And among us, we're always saying to each other, oh my gosh, the depression is so elevated in these kids, especially the teen, the anxiety is so elevated. And one of my friends said to me, well, is it any different than it was a year ago? And I said, well, of course it is. And then I thought, wait a minute, I actually need the data on this. So here it is. Looking at rates of depression and anxiety from April to June in 2019, this is the number of adults, this again is adults, who endorse symptoms, not a full diagnosis, but symptoms of anxiety, symptoms of depression. So in 2019, 8% of adults endorse symptoms of anxiety, 6.5% endorse symptoms of depression. Now look at the rates from this past spring, right? 3 times the level of anxiety in adults, and 4 times the level of depression in adults. All right, and so in the 2020 sample, 26% reported at least one trauma or stress-related symptom, PTSD or acute stress disorder symptom, and 10% self-reported an increase in substance use related to the pandemic. Again, something we're hearing about all the time, friends joking about alcohol use, lots of postings on Facebook and Instagram about it. Here are some data to help us think about it. Now, in terms, again, of risk factors, the symptoms are higher. The Sizer group found that the symptoms were higher among emerging adults, meaning that, 18 to 25-year-old group, people of color, specifically the African American, Black, and Latinx, and Hispanic folks who participated, unpaid caregivers who are taking care of adults. This is a group I'm not sure we pay enough attention to, and essential workers all had higher levels of anxiety and depression. So with a lot of time and energy, and Mara knows that, I'm pretty stubborn and determined, this is all I could find on kids. I'm sure there's other stuff that I missed, but this is what I was able to find. Janice Sprang and her colleague did a study in 2013. They had almost 400 parents report on themselves and on their children levels of PTSD, and these are all folks who've been exposed to pandemics. Could have been H1N1, SARS, avian flu. The study was done in spring of 2009. And they looked at the rates of PTSD. They compared parent report on self and parent report on child. And we all know that parent report on child for PTSD isn't ideal, for sure, but this included some very young children. So this was how they collected the data. And if you look at the families where there was no quarantine or isolation, you see 2 things. I have 2 take-homes here. One is the rates are pretty low of PTSD, but the one that's higher is the parents themselves. And again, this is what we saw after 9/11. Our caregivers were much worse off than our kids. The second take-home point here, which is pretty clear, is if you look at this last row, so for the families where there was a quarantine or isolation, the rates of PTSD are significantly higher. We see 28% of parents saying they've got PTSD, and they're estimating that 30% of their kids have it. So this sense of being isolated, quarantined, which has all sorts of pieces to it. Of course, there's a reason why someone's quarantined, is associated with much higher PTSD. Now, if we go to the broader literature on trauma, there's some additional information I want to share with you on risk and protective factors. We know from study after study that closer physical proximity to a disaster is associated with more higher levels of symptoms and more types of symptoms. Here, I'm trying to equate it to COVID, so I kind of hypothesize that if you're living with someone who receives health care, if you're living with someone who is in healthcare, meaning you guys working in healthcare, or has a disease, that sort of seems to me like physical proximity. Closer emotional proximity, which is being impacted by the trauma, mostly with deaths of loved ones. A loss of a sense of control, predictability, and safety. We talk a lot in my clinic about creating predictability and controllability for trauma survivors, because that sort of defines what trauma does. It takes away that predictability. And right now it's hard to put it in there. The schools are trying, we as child development people are trying. It's tricky. Another risk factor is exposure to secondary adversities. That could be displacement in the context of child maltreatment. Here, it could be loss of home, school, community. Many of these things are happening to kids. Other stressful life events that happen during the trauma itself. And, it's fascinating because you all know that the calls to child protective services are way down. But those of us who do that work are actually assuming that the rates of abuse and domestic violence are way up. And we won't know that until we can get better assessments of those things. Another risk factor that we're seeing very relevant today is the concrete needs not being met. And lastly, the 9/11, there's a series of papers that were done after 9/11 that show extensive media exposure for children and adults is not helpful at all. Okay, other risk and protective factors that are really important for all of us to be thinking about, and then we're going to move into interventions. The most powerful predictor of mental health status post-trauma is mental health status pre-trauma. And if you think about that for like 5 minutes, you'll go, oh, of course, right? So if even with stressful life events that are wonderful and beautiful, I remember when my sister got married, everybody in my family just became a little more of who they already were. So I somehow became the family therapist. My aunt became, a little more selfish. My sister's mother-in-law became a little more vain. I mean, it really, like, we all become ourselves more in any kind of stress, including wonderful things. So that's what happens here too, right? If I'm an anxious person and something terrible happens, I'm going to be more anxious. If I'm a depressogenic kind of person, same thing. So you have to really, this becomes so important for mental health professionals to pay attention to, because it means that the kids that you're already seeing are the most at risk for having severe reactions to COVID. Lifetime trauma is a risk factor. Comorbidity is a risk factor. Now, how people process what happens can be a risk or a protective factor. So when we see self-blame or thoughts about the world being a dangerous place, those are risk factors. If we are around kids who have more of a sense that they have control over their small world, that they can make good things happen, that the sort of COVID, that they think about it as sort of this accidental, like, well, sometimes bad things happen, those kids are protected. Same is true with the family functioning piece. If you've got high family conflict and low cohesion, that puts you at risk. If you have low family conflict, high cohesion, you're protected. Coping skills are key protective factors here. And I think there's been a lot of really excellent work trying to get coping skills out into the general public. I think schools are trying to do it with mindfulness and other skills. So we want to really, really promote coping. As I mentioned earlier, social support regardless of the type of trauma or bereavement, regardless of the age of the person, regardless of the mental health problem, social support time and time and time again is protective. And so what we're working on now, of course, is how do we make sure that the children feel like they have social support in the context of, stay at home and this hybrid learning and all that stuff. And lastly, caregivers who have better knowledge of parenting and child development are also protected, both themselves because they have that sense of self-efficacy, but their children as well benefit from that. All right, so let's talk about interventions, because that's the take-home points here. I believe we need to use research to guide our practice. And so I want to talk about 3 levels of intervention. And for each one, I'm going to kind of talk about what it is. I'm going to give a little research, and then I'm going to give you some resources in case you want to follow up. So our first level of intervention is what I would call sort of the immediate or crisis intervention. And this is where safety and routine are the primary goals. And how do we accomplish that? Through education, normalizing, and some case management. Our second phase of intervention is what I would call the transition or preventive intervention phase. And the idea here, the ideal, is that we want to kind of get in there, and the trauma has happened, but the mental health problem hasn't kind of consolidated yet. It hasn't really dug in. And so we have an opportunity to intervene and prevent the development of the mental health problem, although the trauma has already occurred. So here we want to identify children and adults at risk, and our intervention is going to be all about coping, social support, really focused on these protective factors and trying to build them up. Our third phase is the long-term phase, and here we're really talking about treatment. We're talking about kids and adults, of course, who have mental health consequences to the trauma, and those are pretty set in there, and they really need a more intensive intervention. So let's start with this immediate crisis intervention idea. Let's think about our goal. If it is normal, as I said, 94% of women through the ER. So if it is normal to have symptoms, and the large majority of people do show some recovery over time, why are we going to bother? Why would we intervene? Well, I would argue that, number one, symptoms are painful, and it'd be great to not have that. But even more importantly, symptoms cause functional impairment. And what I mean by that is once the symptoms start, kids can sort of alter their trajectory from where they were in a functional way to start doing other things that are impairing to them. So the initial symptoms for children can affect academic functioning, peer relationships, family, eating, sleeping, basic things that they need for healthy growth. And we see the same thing, frankly, with adults. It can affect their job performance, their relationships, their functioning, eating, sleeping, etc., and their parenting, which we know really matters for their children. And of course, this functional impairment can cause longer-term mental health problems. So you're sort of intervening to stop a cycle. Now, it's interesting because many of us before graduate school volunteered at a rape crisis center or on a hotline doing this sort of crisis intervention work. It's a wonderful opportunity to learn what clinical work was like without needing a degree. What's alarming to me is how little we know about whether any of that stuff actually helps. So there have been very few randomized trials of hotlines and other forms of crisis intervention. There are 2 studies that came out recently that impressed me that I wanted to share. One is this 2019 study that compared psychological first aid, which I'm going to describe to you in a minute, to a group conversation. So just talking to each other after you watched a distressing 5-minute video. And they found that the PFA was better on measures of anxiety and positive affect. Now, of course, this is very I don't know. Hard to know how generalizable this is in terms of the situation itself, watching a 5-minute video, but at least it's got a sort of scientific methodology and a randomized trial, and so it's interesting. I think it's the beginning of what could be a really interesting program of research. This other group took PFA and looked at it in training. So the first study is looking directly at people and how those distressed people responded to PFA. The second study is looking at trainers, so that those trainers would be implementing PFA. So what they did was they compared PFA versus a control in a cluster randomized trial. They were looking at health units in Sierra Leone. And what they found when they compared the trainees who were learning PFA to the trainees who were learning a sort of a comparison, like a placebo comparison condition, they found that those who learned PFA had higher acquisition of knowledge of appropriate responses and skills. So that's great. The negative to this study is at the time of my reading it, they hadn't published anything showing whether that mattered. So if you can train people on PFA, which we really need to be able to do, does that have an impact on actual trauma survivors? We don't know yet. Now, there is some work that this should have a big circle with a line through it. I'm mentioning critical incident stress debriefing because I don't want you guys to do it. Critical incident stress debriefing was developed years and years ago under the idea that emergency service personnel, firefighters, police, etc., have incredibly stressful jobs, and we want to be able to prevent them from developing secondary traumatic stress, which is PTSD due to somebody else's trauma. And so we want to be able to prevent this PTSD. And the idea was if they're sort of running into the fire, doing what they have to do, they run out of the fire and someone's there and they can just kind of detail what they just saw and felt that would prevent PTSD. And without adequate science, frankly, it was used and promoted by major organizations, including the American Red Cross. And Foa, who I mentioned earlier, actually did a study on critical incident stress debriefing and found that it's iatrogenic. In fact, the folks in the trial who got CISD had higher rates of PTSD than those who did not get it. So this idea of kind of detailing, your daily experience as a mental health or pediatrics or whatever provider, only do it if you think it's helpful to you. Don't, if it feels counter to who you are, if you feel like you are better off kind of packaging your day and going home and having separated life and experiences, that's what you need to do. Now, what is psychological first aid? Our idea here is we want contact with families who are struggling. We want to be able to engage them. We're promoting safety and comfort. That's our primary goals here. It's not a mental health symptom reduction model. It really isn't. It's about stabilization and case management. We want to find out a little bit about what their current needs and their concerns are. We're not going to do a formal mental health screening. If you do it too early, you're going to over-identify the number of children and adults who need services. What we want to provide there is practical assistance, connection with social support, as I said earlier, information on coping, psychoeducation on stress, and we want to link them to helpful services. So as you can see, I think it's important for us to talk about this, but this isn't a mental health intervention per se. I do think it helps people's mental health, but I don't think you need a mental health degree to do it. And in fact, the people who are trained to implement PFA do not necessarily have a mental health degree. So for those of you who are interested in PFA, learning more about it, there's a lot of great stuff online about it. There's actually an app, an iPhone app for PFA, and lots of good educational materials. So feel free to check that out. All right, phase 2, this preventive interventions, which I think is kind of where we are now, even though we're not quite done with COVID. I think we got to start paying attention to how this is affecting children. Now, our goals in preventive interventions are to reduce current symptoms, prevent the development of long-term problems, identify and mobilize existing coping skills, potentially lower the need for formal mental health treatment. That's our goal here, is to not have to have long-term therapy, and identify the need and refer for treatment if warranted. So what do we know scientifically? There have been a few interesting studies, and the ones I'm presenting here are all included children. There's other work, including by NFOA, on adults. So the first study, that's me. I developed a brief manual, a CBT manual after 9/11 called Coping After Stressful Times, and it really focused on the psychoed and the coping skills. No imaginal exposure, no in vivo exposure, no intense cognitive restructuring, none of those things. And what we found was that the Coping After Stressful Times was more efficacious in preventing anxiety disorders than a debriefing manual or routine community care in children who came to the emergency department in Oklahoma City. And the PI on that was a woman named Jane Zalewski. I had the pleasure of working with her, and she's just amazing. The second intervention that's also kind of this preventive intervention idea is something called Child and Family Traumatic Stress Intervention, CFTSI, for those of you who know well. And they found that the children who received it were 65% less likely than comparison youth who had been through trauma to meet criteria for PTSD 3 months after the disclosure of the trauma. So really shows that preventive intervention piece. And Steve Marins and his team did that paper. And then lastly, Skills for Psychological Recovery. I'm going to talk about that program today. This program has shown large reductions for children and adults in disaster-related distress, and Melissa Breimer has taken the lead on that. Before I get to talking about Skills for Psychological Recovery, I want to mention this incredible study that Ken Ruggiero and the team at Medical University of South Carolina did. They used address-based sampling, so kind of randomly selected based on address, to enroll families, regardless of mental health status, starting 4 months post-tornadoes. And I believe this was both in South Carolina and Georgia they recruited from. They ended up with almost 1,000 randomly assigned families that were assigned to 3 groups. Bounce Back Now, which is a team-based program. It's 4 multi-session modules, so each module can be used as many times as the kid wants, for teens on PTSD, depression, cigarette use, and alcohol use. And then the second condition was BBN plus a 7-module adult self-help for mental health and substance. And then the third condition was assessment only. The assessments were conducted in 4 and 12 months post-baseline, so it's really nice follow-up. And they found that teens in both BBN plus the adult self-help piece, so basically the 2 experimental active conditions, had lower PTSD and depression at 12-month follow-up. And what's fantastic, of course, about this study, in addition to the quality of the science, is that everything was an app. So really easy to implement. All right, I want to talk for a few minutes now about Skills for Psychological Recovery. I'm really a fan of this. It lines up beautifully with the manual that I had started to develop years ago. And it really is all about promoting those protective factors that the science tells us should be our focus during this phase 2. So after safety, security, and other needs have been met and the community is rebuilding, that's where Skills for Psychological Recovery can be great. It's designed to be 4 to 6 sessions, not full therapy here starts with assessment of symptoms and coping skills, and then it goes into the actual skill building. And as you can see, there are 5, focus areas here. One is we want to build problem solving. The second is we want to promote positive and pleasurable activities, also known as behavioral activation. Number 3, we want to manage physical and emotional reactions to upsetting situations, also known as relaxation or emotional regulation. 4, we want to promote helpful thinking. There's our cognitive piece. And lastly, we want to rebuild our healthy social connections, our social support. And then, of course, at the end, we want to repeat our assessment. If the child or adult is better, we are good. If not, then of course, you're going to make that referral to a longer-term evidence-based intervention. There's some great information on skills for psychological recovery on the NCTSN website. I also want to say that SPR, Skills for Psychological Recovery, has been adapted for language and culture. It was used for some of the hurricanes in the Caribbean, Puerto Rico. It's also been used for kids who have secondary stressors due to being in foster care. So it's got some nice adaptations as well. The last thing I want to talk about here is full-out treatment. So this happens when you've had repeated assessment of trauma-related mental health symptoms and functional impairment, and we have a problem. The trauma-related symptoms are continuing or they're worsening. Then it's time to access evidence-based trauma and grief therapies. Now, we are in the process of doing this at my clinic. We are learning about adaptations via telehealth, adaptations for COVID-specific issues. Some of those adaptations may be thinking about what exposure to trauma means and how do we conceptualize that for COVID, the types of psychopathology we're seeing, as I mentioned earlier, and some of these implementation challenges that I'm sure I don't have to tell you guys about in terms of location, developmental challenges with the little ones on the platforms, a number of sessions, how do we do supervision, all of it. We're learning a little bit as we go. But for those of you who don't know, and I'm sure many of you do, there's some really great evidence-based treatments out there for traumatized children. I'm going to focus on a couple that I think really stand out in the disaster work. One is trauma-focused cognitive behavioral therapy. And as Mara mentioned, I am a trainer in TFCBT. This is a model that focuses on the individual child and the individual caregiver and then builds towards some family work. The second model that I focus on is called CBITS, or Cognitive Behavioral Intervention for Trauma in Schools. This was developed by Elissa and her group, and this takes place in schools where the primary recipient is the children, and parents get, I think, 2 kind of parenting psychoed sessions. There are many good treatments for trauma-related psychopathology, and the NCTSN has a list of the different trauma treatments and the degree of science behind them, including the model Mara mentioned that I co-developed. These are the 2 I want to focus on right now. So when we think about evidence-based trauma treatment, what do I mean? What am I even talking about? And there are some common elements that cut across most of the evidence-based models. We start with assessment. Then we have our psychoeducation. There's a parenting piece of it. And I think, we think about parents here both as in need of their own coping strategies, but also a coach for their child to make sure that the child is using the coping strategies. In addition, some of our parents really need help with some parent management. So that's a part of it as well. We're going to work with everyone to do a better job at identifying affect and then manage affect dysregulation or affect upregulation using relaxation. One of the biggest predictors of reductions in PTSD during treatment is challenging of those negative automatic thoughts and distortions that we see with traumatized kids. So the cognitive work is really important. And then we do exposure work. Sometimes it's imaginal and or in vivo exposure. That's an integral part. And then the coming together as a family and talking about the trauma and building safety in as that child continues to develop. So I think most of you know that trauma-focused cognitive behavioral therapy is the most rigorously tested treatment for traumatized kids with minimally subclinical PTSD. There are more than 20 randomized trials that have been conducted at this point, and those trials have shown improvements in children's PTSD, depression, anxiety, and behavior problems compared to supportive psychotherapy, client-centered therapy, routine community care, et cetera, et cetera. TFCBT has also shown improvements in caregiver distress, caregiver support of the child, and caregiver depression compared to supportive treatment. We know that it is effective in both individual family, where it's mostly been studied, but also in a group format, assuming that the exposure piece is pull out. The exposure piece is always done individually. It is not done in a group. It is highly, highly, highly discouraged to do it in the group format. The science here is great. They've shown follow-up studies that the symptom decreases are maintained at 2-year follow-up, and that these findings have been replicated and generalized across racial, ethnic, and geographic boundaries. TFCBT has been implemented in, I don't even remember anymore, dozens and dozens of countries all over the world. And we, at Child Health Partnership, serving this low-income multicultural population, our effect sizes are the same as the ones in the randomized trials. I'm so happy to be able to say that. Now, TFCBT and CBITS were both offered to families after Hurricane Katrina. And as I mentioned, CBITS, school-based model with very little parent involvement, also good outcomes, not as many studies as TF, but certainly a promising practice. So the way this naturalistic implementation study worked is that 195 students participated in baseline assessments 15 months after Hurricane Katrina. 60.5% of them, I'm always fascinated by a half a person, but anyway, 60.5% screened positive for significant PTSD symptoms. And that group of 60% were offered TFCBT or CBITS. TFCBT at a clinic, CBITS in school. And what I find fascinating about this is that many more families chose CBITS than chose than chose the clinic-based TF. Not surprising, right? Easier for families. The show rate for the CBITS was 98%, which is, of course, the benefit of a school-based mental health program, versus 37% for TFCBT at the clinic. But the improvements were slightly higher for TFCBT, and I would hypothesize it's because of the parent involvement. But it gives you options, and I think that's really important in a time like this, right, when we're all just doing our best. This gives you some good options. I want to quickly talk about children's grief. It's a major, major issue in the trauma world, and we've got some good studies. I would say the best treatment for children's grief, the most well-studied, is Erwin Sanders' Family Bereavement Program. This is a group model, as is Goodman's Making Connections. They do 12 sessions, 10 group and 2 individual, and the goal is to promote adaptation to stressors and reduce risk factors. These grief models are not pathology focused. They're really not. It's all about coping and parenting and kind of normalizing that the death of somebody significant can be very hard. Sandler's done 2 randomized trials with 1 long-term, and when I say long-term, I mean 15-year follow-up, showing lower mental health symptoms in children and their caregivers versus the control condition. So he's had real success here. It's arguably a preventive intervention as much as it is a treatment, but it doesn't matter. It might be splitting hairs on my part. Thinking Connections, Robin Goodman, who's somebody I work with a lot, and I'm about to mention her regarding a 9/11 project I did. She has also a group model where the families are divided into 4 groups: littles, ages 5 to 7, middles, age 12-year-olds, teens, and caregivers. And they meet for 11 weeks. Each group is having the same theme, but done in a different way with different language. Psychoed about bereavement and grief, CBT coping skills, some family communication, parenting, and meaning making, which is great. I work with Dr. Goodman, and I've evaluated her program, and we have found significant reductions in grief and depression and increases in post-traumatic growth, which is really important after a significant death for both children and their caregivers. The last study I want to mention is the study that I did with Dr. Goodman and also Judy Cohen and Tony Manarino, who are developers of TF-CBT. We looked at traumatic grief. So I've reviewed the literature on trauma studies, treatment outcome studies, literature on grief, treatment outcome, and now I want to talk about traumatic grief, which has this element of grief plus PTSD plus depression. And we saw it in a lot of families after 9/11. So we did a study here with the families of the uniformed service personnel who were killed in the line of duty on 9/11. So in this case, it was all mothers and children of the firefighters, Port Authority, police, and EMS who died in the towers. And it's a very small randomized trial, only 40 kids, and they were randomized to either TF-CBT for traumatic grief or client-centered therapy. And it's interesting because what you have in front of you is actually the graph for the mothers. And the reason is because with the kids, we found that the kids in both groups improved, but not differentially. And that we're hypothesizing is because at baseline, the kids were not highly symptomatic. Now, in contrast, the mothers were more than 2 standard deviations above the mean on the PSI scores at baseline. The mothers were highly, highly, highly symptomatic. Now, as you can see, we randomized them to our 2 groups. Our TF group is in blue and our client-centered group is in red. And randomization doesn't always work as well as you want it to. You can see that there are baseline differences that we had to co-vary. But I think the message is really clear. These women were struggling. And if you're not struggling too much, then either of these models can be helpful. And I'll tell you, we see that in the literature, that a supportive psychotherapy is fine with a little bit of anxiety. But if you've got a kid with PTSD or a real anxiety disorder or serious depression, CBT does better. And what I like to say to families is it makes you more, better, faster, which is not good grammar, but it's true. So you see what happened here. These moms showed much greater change with the TF condition, even accounting for, covariating out the baseline differences than in the client-centered condition. So this is a study that absolutely warrants replication, no question. So what are our next steps? What do we need to be thinking about now? Well, one, we need to really understand the association among children's exposure to COVID, the risk and protective factors that I've listed out, and the consequential mental health problems. We're doing a study of that right now in Queens, trying to understand the interrelationship here. The second thing we need to do is study the efficacy of these evidence-based interventions for COVID-related mental health problems, and we're starting to think about doing that as well. If you're interested in any of this or want to participate in any way, follow us, Child Health Partnership on Facebook and Instagram, or feel free to email me. I would love to take some questions.
Thank you so much, Dr. Brown, for this timely, insightful, and informative presentation. I learned just a lot today to help our kids here. And a lot of this, I think, hit home for me working with children and adolescents during this time. For example, the sleeper effect. I mean, we're seeing such an increase right now in acuity and hospitalizations. We have a lot of people in our emergency room today waiting for beds. And this wasn't the case during the spring, right? It's not the same. So there was just so many points that you made, I think, that are just shedding some light on what we're experiencing right here, right now. So I do have a few questions from some people who've emailed and texted me. I'm going to start with Vanessa, if I can find her here and unmute her. Let's start here. Okay. Vanessa, are you there?
Can you hear me?
Yes.
Oh, okay. Hi, Dr. Brown. I actually had a few questions, but I think some were answered as your presentation went on, and thank you for it. But one question I have is, any thoughts or concerns about how the pandemic may impact the development and functioning of like very young children, like birth to 3 born into this?
Yeah. I do. It's so funny, Vanessa, that you would mention that. I just had a conversation the other day with a colleague of mine who is another trauma psychologist, but really has that early childhood expertise. And she was so astutely pointing out all of the things that are not happening for young children that would normally happen, right? So they're not going to go to the playground and sit in the sandbox and have their toy that they brought, and then there's another child with another toy, and how do you share space, and how do you share toys? And it was just such an insightful comment. I think yes, I think there will be issues. I also think parents are under tremendous stress, and having a young child right now is really difficult. And I think that could affect parenting and, of course, the parent-child attachment. I also think kids who normally have separation anxiety from 9 months to 15 months old aren't having as many opportunities to separate from their caregivers. So I think it's a great question and a little bit to be determined.
Thank you.
Mm-hmm.
I have another question from Julia Page, who's one of the clinicians in our inpatient unit. Any specific challenges or changes in implementing some of the trauma-focused therapies with the use of telehealth or disruption in school-based services?
So, how much time do you have? Yes and no. Yes and no. I will say that, and Mara knows as well, like when the pandemic hit and St. John's decided to close our clinic, I went to work. I mean, for 4 days straight, 6 hours a day, I was on the phone with everybody at St. John's to move us to telehealth because there was no choice. We had to. And as Mara knows, like St. John's is not the most like innovative, get it done fast kind of place in the world. So it kind of, now that all seems like, well, of course they should have done that. But what I did was I went to people who know more than I do. So I have a colleague named Michael D'Ariano, who is also a TF-CBT trainer. We're pals from internship, which I did actually at Medical University of South Carolina, where TF-CBT Web was developed. And he's been doing TF-CBT Web he's been doing TF-CBT via telehealth for about a decade. And if you guys want, I'm happy to send you links to 2 really great webinars that his team has put together, plus a couple of articles they've published about how to do this online. I think our biggest challenges, frankly, are with the 5 to 7-year-olds. I mean, we're doing it, we're trying, we're struggling, but they, as you all know, because you're hearing about it from teachers and parents, these kids do not want to sit in front of a screen any more than they have to because of school. So we're doing all sorts of creative things. We've taken the psychoeducation, what do you know game, and we've kind of put it online as a trivia game. We're doing what we can do. That's a tough group. I'm happy to share those resources. I will say we're also having a lot of success with families. It's unbelievable to watch a trauma narrative, which is the imaginal exposure, unfold online. It's happening, and it's beautiful. It's wonderful. You guys just have to tell me who I should send the resources to, and I will send them.
You can send them to me, Vanessa, and I can forward them on. Thank you.
Of course.
One more question, if you don't mind. So this is from Megan Rock. She's a clinician in our ambulatory program and the IOP. She's wondering if you found any of these interventions to be helpful for children on the spectrum. This is the population they're seeing the most right now due to COVID-related disruption in routine and schedule.
Okay, so totally validating the thinking and the concerns, love it. I'm thrilled to say that my friend and colleague, Peter D'Amico, who's at LIJ, has an NCTSN grant to do just this. He is adapting TFCBT and a lot of other kind of assessment services for traumatized kids who are developmentally delayed and or on the spectrum. So I'm going to add that to the stuff that I'm going to send. I think that what Peter would say, and he's this is totally what he would say. We adapt TFCBT to every kid we see because we're trying to maximize the perception of success. We want the child to feel like they're really successful at accomplishing what they need. And so we would translate TF to children with learning differences as well. So he has put together a lot of kind of, if the kind of auditory processing isn't great, then we go to more of a visual. If the visual isn't great, he really has done a beautiful job concretizing the TFCBT steps. A narrative doesn't look the same for a kid on the spectrum, not for some. So I think it's a great question. I think we have to get better at this, and I'm gonna connect you to an expert in that.
Thank you.
Mm-hmm. Yeah, great. All right, so telehealth and spectrum stuff. Good. What do you think, Mara? One more question?
Yes. So a question about working with caregivers. So you had mentioned before that caregivers tend to experience even more symptoms at times than the kids. So how would you work with caregivers who are struggling as much or more than their kids, but are help rejecting and focusing on the kids who become really the identified patient in the situation?
Yeah, so that's an excellent question. I would say that there are three ways that we get families. One is the parent who's really struggling, who wants help, but doesn't know how to ask for it for themselves, so they make it about the kid. The parent who, the kid who is struggling, who, the parent makes it all about them. And then there's the parent that you're talking about, right? Who the parent is struggling themselves, but they're no, I'm fine. I'll just drop her off. And yeah. So one of the things that I think helps right from the get-go is establishing what TFCBT is. It is a parent-child intervention. That's what it is. If you don't want that, then you can have individual therapy. And of course, we could do half of TFCBT just with the child. But TFCBT is designed to have a session with the child and a session with the caregiver, not a 15-minute check-in, but a real session. And I think when you establish that from the get-go, and the parent's like, well, I have to be in the room anyway, right? Then that barrier of like, how am I going to get them in the door? No. From the minute you've described the model and said, is this something you're interested in? It has the best outcomes. Here's how it works. It's a short-term model. That's number one. You got to be honest right from the get-go and set those expectations, which Mary McKay would say, big predictor of engagement in treatment is people knowing the expectations up front. I think the second piece, and I talk all the time about this when I'm on my consultation calls, because plenty of parents come in the room, but they don't really participate, is it is on us to convince our clients that what we have is worthwhile. This is mental health in 2020. This is not mental health in 1980. We don't get to sit there and just wait till they walk through the door. That's not how it works anymore. And frankly, we should all be taking a marketing class in graduate school because that's part of this. So how do we do that? We have to figure out, I would use a CBT framework and a functional analysis, which is my case conceptualization format, to figure out what will make the caregiver's life easier. Because if I can identify that and show them that something about my coping skill toolbox, something about what I have to offer, my problem-solving paradigm, will make his, her, their lives easier, then I've got a better chance in engaging them. And by the way, who would blame them? Why do they want to spend time doing something that's not going to make a difference in their lives? I don't. So, yeah, those are just a couple of things to think about.
Great. Thank you so much for those recommendations. And we actually have some more questions. So what I'll do is I'll probably just email you some of them because your lecture was just so informative and really timely. So I will definitely email you some of those questions to get some follow-up. And thank you so much for this wonderful presentation today.
Oh,
and it's great seeing you.
It's so good to see you. You look great. You're in a great place. You know that. And I was so pleased when I spoke to you guys, to Vanessa, and I said I could do this or I could do this, and you guys said do the disaster mental health, and I think it was really the right choice. This is where we are, and I'm going to take this presentation probably to other sites as well because people are asking for it now.
Exactly, it was great. Thank you so much.
Thank you all. Have a great day, everybody.
You too. Thank you.
Sure.